Hello, my name is SHI Moloney, and I'm an assistant professor at the University of Kentucky. Today I'm going to take a few minutes and give you a virtual abstract of my upcoming article in Sociology of Health and Illness. My article is entitled, "Sometimes It's Easier to Write the Prescription: Patient and Physician Accounts of the Reluctant Medicalization of Sleeplessness." Prior to this work, I published a quantitative piece looking at sleeplessness-related outcomes of physician office visits. What I found was that over a 15-year period of time, sleeplessness complaint, insomnia diagnosis, and prescription of sedative hypnotics all increased significantly over time. But there was a real gap between the prescription hypnotics and everything else. In short, the prescriptions of sedative hypnotics far outpaced either complaint or diagnosis of insomnia. I set out to investigate this gap by interviewing 27 patients who had been prescribed sedative hypnotics and their 8 prescribing physicians. Now, what I found was that there does appear to be medicalization occurring within the physician office visit, and this may help explain that diagnosis-prescription gap. Medicalization, of course, is the process whereby formerly normal life issues or biological processes are transformed into medical problems with medical solutions. Notably, in my sample, neither doctors nor patients conceptualized insomnia as a biomedical problem, and they rarely reported daytime impairment. In fact, when I asked them what caused insomnia, they cited common life occurrences like stress, aging, or even grief. Like previous work, there was a gender component. Men were more likely to cite work stress as being the cause of their sleeplessness, and women were more likely to cite multiple caregiving and responsibility roles as the cause of their sleeplessness. Now, perhaps most interesting was the contrast between self-reported attitude and actions in the sample. Even though these patients were requesting and taking sleep drugs, and even though the doctors were all prescribing them, they all expressed great reluctance towards these drugs, and thus I call it a case of reluctant medicalization. Being sleepless or taking sleeping pills was not stigmatized, and this fits into our cultural norms of having a productivity imperative or sleeping when you're dead. But at the same time, doctors in particular said that sleeping less as we age was natural. It reflects a shift in the circadian rhythms, and they really worked to change patient expectations, but patients just wanted a pill. Patients, for their part, told me that they had tried everything before they got a prescription for a sleep aid, and even once they had the prescription, they tried not to use them too often. They cited concerns of addiction or dependence on these pills. I also sought to better understand these complex interactions by revisiting Peter Conrad's fundamental work on the engines of medicalization. And what I found was that all 4 of the most common engines, that is, consumerism, biotechnology, managed care, and the intent of physicians to reduce suffering, these were all very present and active in all of these accounts. Physicians in particular felt very constrained by managed care, by the time limits they had with their patients, and by the role of insurance companies. And as one physician told me, sometimes it's just easier to write the prescription. In sum, these data add to a growing literature that acknowledges nuanced medicalization processes. Patients and physicians in my sample chose to inhabit a liminal space between pathology and normalcy. On the one hand, they acknowledged that they were treating life problems like aging, stress, or grief with medical solutions, in this case sleep aids, which are minimally effective and can cause dependence and other side effects. Thank you very much for watching this video abstract, and I hope you get a chance to read my article.